So this presentation is on the mental status exam. I'm David Petrucci. I'm now in R3. I initially wrote this presentation last year. Objectives for the presentations. Number 1, answer what is the mental status exam. Number 2, answer what is the goal of the mental status exam. Number 3, listen to find the components of the mental status exam. And number 4, utilize the above objectives to perform a mental status exam. So what is the mental status exam? Well, you've probably heard this statement said before. The mental status exam is the physical exam of psychiatry. I would challenge you to increase this definition to the mental status exam as the physical examination of the mind. What is the goal of the mental status exam? Well, essentially what we're trying to do here is to recreate how the patient presents to us at the specific time point in which we saw them, so that another person, say a psychiatrist or another resident or medical student, is able to recreate that person in their mind and understand the pathology that we saw at that specific time. So a common mnemonic used to remember the components of the mental status exam is aseptic. We'll go through this now. So A stands for appearance, S stands for speech, which can be broken down into 3 common components. These are rate, rhythm, and volume. So E stands for emotion, which is divided into both mood and affect. Mood is a described emotion, while affect is the emotional performance or perceived emotional tone. Several types of affect bear mentioning, which we'll go through now. These are blunted, constricted, flat, inappropriate, and labile. In blunted affect, there's minimal expression and intensity of emotion with little variability. Patients are perceived as monotonous. In constricted affect, there's limited range and variability. In flat affect, there's no effective expression. It's as though you're talking to a wall. In inappropriate affect, speech and emotion don't match up. And in labile, changes in emotional tone occur quickly without warning and very frequently throughout your interaction. So the P is for perception, and of course there are many types of perceptual errors that we can make. Common differentiating factor between hallucinations and illusions is the presence of external stimuli. In a hallucination, no external stimuli is present, whereas in an illusion, external stimuli is present. An example of an illusion would be driving down the street, listening to the radio, and hearing your name being spoken aloud, although it has not been said. Whereas in an hallucination, you may be sitting in a quiet room without anyone else present and hear your name being spoken. We also talk about déjà vu and jamais vu. So jamais vu is the feeling of unfamiliarity with familiar situations, whereas déjà vu is the feeling that one has already experienced a particular moment or event before. I think we've all commonly had this experience, not just those of us with temporal lobe epilepsy. We also talk about the difference between derealization and depersonalization, which I think is important to differentiate between. So in depersonalization, the person has an altered sense of one's physical being. It includes feeling outside of one's body, physically cut off or distanced from people, floating, observing oneself from a distance like one is in a dream, or that one's body is physically changed in shape or size. Whereas in derealization, the person has a sense that one's environment has changed and is different than the way it had been before, though the individual cannot identify tangible elements of that change. So T stands for thought process and thought content. Thought process is the so-called how of speech. A number of terms deserve definition here. So we'll start with circumstantiality. So this is speech that takes a circuitous route before reaching its goal. Extra unnecessary and sometimes tedious details are added. The speaker often needs to be interrupted. However, there's a clear recognized link between the associations. Tangentiality. So this is speech that talks past the point and never reaches the goal of answering the question. It's similar to circumstantial speech, but in contrast to loose associations, as we'll see, there's a clearly recognized link between the associations. In contrast to circumstantial speech, the goal is never reached. Clang associations. So this is speech in which the sounds of words, rather than their meaning, guides the choice of words. Puns and rhymes are characteristic. For example, where should I lie? If I lie, will I die? Go to the sky, way up high? Distractibility. This is attention to the interviewer is easily disrupted by unimportant stimuli. Flight of ideas. So this is rapid speech with abrupt changes from topic to topic, usually based on understandable links between the topics, distracting stimuli, or plays on words. When severe, the link between the associations may be so obscure that loose associations or incoherence may also be present. Illogical thinking. So this is thinking that contains clear internal contradictions, or in which conclusions are reached which make no logical sense. For example, my mother died before I was born. Incoherence. So this is incomprehensible speech due to disruption of logical or meaningful connection between words or phrases, many incomplete sentences, idiosyncratic use of words, and distorted grammar. Then loose association. So this is speech characterized by a disruption of logical or meaningful connection between the ideas and thoughts in sequence. Sometimes there is an oblique association between ideas, sometimes there's no association at all. The individual is unaware of the lack of connectedness between the thoughts. Often the interviewer is left wondering what the patient just said. Neologism. So this is essentially a new word. It's a distortion of words or a condensed combination of words created by the patient and which has a specific meaning to them. For example, I futiligated the rocket to outer space. Non sequitur. This is where a response that does not follow from the question asked is provided. It's often used by politicians. For example, where were you born? The answer, I'm not sure if that's the way it's always been or not. Preservation. So this is repetition of the same word, phrase, or idea in response to different questions. This does not include the use of filler words such as you know, like, or I mean. For example, that's my story, things happen, and this is how my story unfolded. My story isn't a very happy one, and I hope my story for the future will be better. Preoccupation, so this is a mental absorption in a particular topic or concern. Pressured speech. So this is rapid, continuous speech that is difficult to interrupt. Rambling. This is speech that is fragmented, without goal, and usually associated with intoxication. And then thought blocking. So this is a sudden interruption in the spontaneous flow of speech associated with the person saying that their mind went blank. Upon questioning, after a period of silence, the individual states that he cannot recall what he was talking about. And then thought disorder, also referred to as formal thought disorder, a generic term that refers to abnormalities in the thought form of thought in contrast to the content of thought. And then word salad, so this is speech that is incomprehensible and incoherent because of a lack of logical and meaningful connection between words. It represents the extreme form of looseness of associations. So thought content pertains to the major themes of speech. Here are several questions for you. So first, what are ideas of reference? Well, ideas of reference are similar to delusions of reference, except the person questions the reality of the belief. For example, a patient wondered whether everyone on the bus was talking about them, but knew this was unlikely to be true. Question 2, what does magical thinking refer to? Magical thinking refers to the belief that thinking something will cause it to occur. This is normal in kids, for example, children avoiding stepping into cracks so they won't break their mother's back. And question 3, what are overvalued ideas? So an overvalued idea is a relatively firmly held false belief that is not shared with members of the individual's cultural religion, which is not maintained with delusional intensity. For example, a patient who is concerned about getting AIDS from a toilet seat acknowledges that they may be wrong, but still wants an HIV blood test. The I part of the aseptic mnemonic stands for insight and judgment. Insight is an awareness of illness and its implications for one's life. Judgment is using the awareness of the illness and its implications in order to make rational decisions about the future. And finally, the C part of the aseptic mnemonic, which stands for cognition, is composed of many domains. These include perceptual motor, complex attention, executive function, learning and memory, language, and social cognition. So that brings our presentation on the mental status exam to an end. So now you should know what the mental status exam is, what the point of it is, all of its components, which can be remembered with the aseptic mnemonic, and be ready to apply it in a clinical setting. As a thought exercise, I would like you now to imagine what the mental status exam of a depressed person might look like and write out a brief description. And once you're done that, do the same thing for a patient presenting with mania. Thanks everybody for paying attention to the presentation. I appreciate it. Again, my name is David Patrician. I'm a R3 in psychiatry. If you have any questions, please feel free to reach out to me. I'm always happy to talk about psych. I'm always happy to talk about life in residency. And I'm particularly happy to talk about research and other academic activities. So have a great weekend. Thanks for your attention.